series for a very warm welcome to everyone who has logged in for our residence webinar series for today. Today is the 9th session of this residence webinar series, and this series is powered by the Educational Committee of the Nigerian Society of Anesthetists. So I am Dr. John Afa Musemene, the trainee representative of the Nigerian Society of Anesthetists. And like I mentioned earlier, this webinar series is powered by the Educational Committee, headed by the President-elect, Dr. Quinette Kalu. So we are grateful to her and to the NSA, led by Prof. Al-Hassan Dati, for the support and the support and the resources to have this series and to keep having them. So as we are online now, please mention in the group that we've started, send the link to your respective departmental groups, because today we're discussing a very important topic. So now I would introduce the moderator for the day. He would come online and tell us and give us the housekeeping rules, and also moderate the session. He will introduce the speaker and the topic. So the moderator for today is Dr. Adeboyega Akintade of the Department of Anesthesia and Critical Care, Federal Medical Center, Ebute-Metta. Dr. Akintade.
Thank you, Dr. John Afa. My name is Dr. Akintade Adeboyega, Senior Registrar. My name is Dr. Akintade Adeboyega, Senior Registrar, Anesthesia Department, Federal Medical Center, Ebute-Metta. I'll be the moderator of today's section, which is the 9th section of the Resident Webinar Series, being coordinated by the Educational Committee of Nigerian Society of Anesthesia, headed by the President-elect, Dr. Quinette Kalu. The presenter for today is no other person but Dr. Aliyu Bashir Adamu, a senior registrar in the Department of Anesthesia and Intensive Care Unit, ATB-UTH Bauchi. So while waiting for others to join so that we can start in earnest, I will encourage all participants to kindly mute their mic and change their name to reflect their name, their official name, and also the center they come from. Thank you. During the course of the presentation, if you have any questions or clarification, residents are encouraged to drop it in the chat box. Then after the section, those questions will be attended to, after which our trainers and our professors will contribute and also guide us as appropriate. Thank you, everyone. Please, while waiting to start the meeting, kindly mute your mic. Thank you.
We can start now. We have enough people. Thank you so much, Dr. Akintade.
Okay, sorry. Okay, thank you then. So Dr. Aliyu Bashir Adamu, please, you have the floor to present today's presentation. So as stated earlier on, the ground rules include, please kindly edit your name to reflect your official name and also your institution. And if you have any questions, please do not hesitate to drop it in the chat box. Thank you. So Dr. Aliyu, you have the floor. So the duration of the presentation will be between 30 to 35 minutes only. So that means if we are starting now, we are expected to round up by 5:40, after which we entertain questions already dropped in the chat box. Thank you.
So thank you very much. Good evening, everyone. Let me just stand on the existing protocol. So our topic of discussion today is perioperative cardiac arrest. My name is Aliyu Bashir Adam from Abubakar Tafawa Balewa University Teaching Hospital, Bauchi. So these are the objective of today's presentation, for us to identify the common causes of perioperative cardiac arrest, and then for us to understand the importance of close monitoring and early detection, and then prevention of the perioperative cardiac arrest. So we'll use the following outline. So introduction, as we know, Perioperative cardiac arrest is a catastrophic complication which requires immediate recognition and correction of the underlying cause in order to improve the outcome of the patient. Usually we use the H&T mnemonic to serve as a valuable tool for us to rapidly get the differential diagnosis whenever we have cardiac arrest. So another new approach has been devised, which includes evaluation of the preload contractility, afterload rate, and rhythm of the heart, which categorize the perioperative cardiac arrest and is very comprehensive, systemic, and then physiologically logical. So we cannot overemphasize the significance of utilizing monitoring gadgets such as the electrocardiography, pulse oximetry, end-tidal carbon dioxide, blood pressure, which can give us clues to identify the underlying causes of the perioperative cardiac arrest. So to aid this investigation, anesthetic care, surgery, echocardiography, relevant check and history, which is abbreviated as ASACH, is a criteria that has been improved, which can be employed during crisis management when we have perioperative cardiac arrest. So epidemiology, as we know, is a devastating complication, and then the incidence varies with time, geographical location, and then the type of surgical cases that have been done. So there is a study which was conducted in 2006 in Lagos University Teaching Hospital, which shows the incidence of perioperative cardiac arrest to be about 6 per 1,000. And majority of the patients are said to be SA class 3 and above. So the commonest cause was identified to be hypovolemia in over 50% of the patient. And then majority of it occur intraoperatively. And then survival was recorded in less than 40% of the patient. Then there is a study in Brazil, in the teaching hospital, which reported 35 cardiac arrests per 10,000 anesthetic based on their data which they collected between 1996 and 2005. Then the National Anesthetic Clinical Outcome Registry in the UK give an incidence of 6 cardiac arrests per 10,000 cases based on 2010 to 2013 data. So if you can see, the instance of the perioperative cardiac arrest is reducing, is more in the less developed countries and then is lesser in the highly developed countries. And the reason will not be because they have more advanced monitoring equipment that they can detect it early and then institute whatever management that need to be instituted. So favorable outcome rely on many factors, particularly the prompt recognition and correction of the underlying cause of the cardiac arrest. Therefore, we need to deeply understand and have a structured approach in order to effectively search for the potential causes and then institute resuscitative measures. So this is the heart that has been arrested. So definition, as we know, any cardiac arrest that occur in a surgical patient from when the patient arrived in the operating room to the time when he is discharged from the post-anesthesia care unit or 24 hours after surgery if he is admitted to intensive care. That's what is known as perioperative cardiac arrest. Usually during the perioperative period, the patient are routinely monitored. So most of the perioperative cardiac arrests are usually witnessed. As a result of that, timely diagnosis is made and then resuscitative measures are being commenced. So this is just a comparison between perioperative cardiac arrest in hospital and out of hospital cardiac arrest. As we can see, the perioperative cardiac arrest is normally related to surgery and anesthetic, and then usually is witnessed, and then the patient are frequently monitored. So resuscitation is usually instituted. There is less chance of it being a witness cardiac arrest, and then patients are usually not monitored. So the outcome is usually bad about 8 to 12% of the cases. So this is the heart looking for help. So this is the PCARR approach, which will help us to find the underlying cause of the cardiac arrest. So if we check the preload, the things that can cause abnormality in the preload include hypovolemia. That can be from trauma, massive bleeding, anaphylaxis, or major venous occlusion, especially if they are doing retroperitoneal procedures. Then another one is right heart failure, which can occur from myocardial ischemia, pulmonary hypertension, or pulmonary embolism. Then the pulmonary embolism itself, which can occur due to either clot, gas, especially during laparoscopic procedure, surgical cement in orthopedic cases, fatty tissue or amniotic fluid in obstetric patient. Then exaggerated use of PEEP, that can increase the intrathoracic pressure, reducing the varus return, therefore reducing the preload, then tension, pneumothorax, and cardiac tamponade. Then in the contractility, myocardial ischemia leading to low perfusion pressure, thrombosis, embolism, or spasm of the coronary artery. If you have myocardial ischemia, that cannot contract well. So the cardiac output will reduce. So that will cause hypotension and then decreased tissue perfusion, ischemia of the myocardium, and then cardiac arrest can occur. Myocardial hypoxia, also acidosis, presence of hydrogen ion, or Takotsubo cardiomyopathy. Then the afterload crisis includes left ventricular outflow tract obstruction, which can be from systolic anterior motion of the mitral leaflet, or severe vasodilatation as in anaphylaxis, or vasodilator overdose, or when we have severe vasoconstriction, which can be from pure chromocytoma surgery, especially when they are manipulating the tumor, or vasoconstrictor overdose. The rate and rhythm crisis. As we know, the rhythm of the heart is usually coordinated, usually from the sinoatrial node down to the other conducting system. So when there is any abnormality, there will have an arrhythmia. Usually, arrhythmia does not produce effective myocardial contractility, so cardiac output will be affected, and that will lead to perioperative cardiac arrest. So this is another table that is just giving us the likely things that will lead to perioperative cardiac arrest, from acute anemia, acid-base abnormality, afterload crisis, left ventricular outflow tract obstruction, hypokalemia, and hyperkalemia, and others. So these are some of the clues that we can get from monitoring. If we see the hallmark of cardiac arrest is decrease in cardiac output. So anything that can lead to reduction in cardiac output, if uncorrected, ultimately will result in cardiac arrest. So using our monitors that we have, the 5 basic ASA monitoring apparatus, pulse oximetry, ECG, end-tidal carbon dioxide, then the blood pressure. From them, we can get a clue to the likely thing that may lead to reduction in cardiac output and then ultimately perioperative cardiac arrest. For example, if we have decreasing SpO2 value from our pulse oximetry, you think about poor peripheral perfusion, or we have reduced stroke volume, likely myocardial hypoxia, airway or ventilation complication, or we are delivering underdosing of oxygen to the patient, or maybe patient is having atelectasis, pneumothorax, or ventilation perfusion mismatch, or our FiO2 is usually low. Then we need to rule out light movement interference, and then if the device is having any issue. So when we have decreasing SpO2, most likely, if there is no device malfunctioning, then it means that there is no enough tissue oxygenation ongoing. So once we have that, we can have myocardial hypoxia. When we have myocardial hypoxia, the heart cannot effectively contract in order to give adequate stroke volume, which result in good cardiac output. So that will lead to reduction in blood pressure, then decrease in perfusion of the coronary artery, and then ultimately the heart will arrest. So from ECG, we can see abnormality of the rate and rhythm from ECG. Can see bradycardia or extreme tachycardia. In the case of extreme tachycardia, the heart will not have enough time to receive its own blood supply, because usually heart receives its blood supply during diastole. When you have extreme tachycardia, the diastolic time is shortened. So most of the time the heart is contracted. So no enough coronary blood supply to the myocardium. So that will make the heart to look fatigue, because it is not getting enough blood supply and oxygen. Then ultimately, the contractility will not become effective, and then reduction in cardiac output leading to cardiac arrest. So that one, we can get clue from our ECG. Maybe you are seeing normal ECG tracing later and now start seeing an arrhythmia. So that arrhythmia, if uncorrected, subsequently, it will lead to cardiac arrest. So ECG is very important monitoring equipment. Then end-tidal carbon dioxide decreasing, as we know, the EtCO2 can give us clue regarding the cardiac output. So once we see the end-tidal carbon dioxide is decreasing, it means that the cardiac output is also decreasing, because usually what goes through the systemic circulation, it was goes to the lung. So meaning the left and right side of the heart, they pump almost the same amount of blood. So once EtCO2 start decreasing, meaning no enough blood carrying carbon dioxide is going to the lung for exhalation, then meaning the cardiac output is reducing. So if that remain uncorrected, ultimately it will lead to cardiac arrest. Likewise, extreme blood pressure, either very high blood pressure or very low blood pressure, hyper or hypertension. In that case, in case of hypertension, it may give myocardial infarction. That will lead to myocardial ischemia, then ineffective contractility, and then cardiac arrest. While in case of hypertension, poor perfusion from the coronary arteries, no oxygen supply to the heart, then the heart cannot effectively contract. So yeah, we can have cardiac arrest from there. So these are the clues that we can get from monitoring. That's why monitoring is very important during the perioperative period. And then the best monitor is usually the anesthetist, because even if the monitoring equipment are giving you alarm, if you are not observant, you may not be able to detect it on time. So what are the actions that we can do from those clues that we get from the monitoring? So this, the ASAT action plan. This ASAT is just a well-arranged things that somebody can need to do in order to correctly and promptly get the cause of the perioperative cardiac arrest. So from anesthetic care, we quickly check the airway to ensure that it is patent, roll out whether we are giving high PEEP to the patient, check ventilation, check our FiO2, roll out bronchospasm and pneumothorax, then oxygenation of the patient, whether the patient is having hypoxemia, then other hemodynamic assessments such as the blood pressure, the pulse rate of the patient, then the anesthetic procedural complication, maybe there is severe bleeding, then vasoactive drugs overdose if we have used any, or local anasthenic systemic toxicity. Then from the surgery, we can quickly check to see whether there is bleeding through the operation field. That will lead to hypovolemia and ischemia. When there is compression, maybe the surgeon is compressing one of the great vessels, especially the inferior vena cava, leading to decrease venous return, which will ultimately reduce the cardiac output. Or there is stretching. For example, when they are doing gynecological procedure, that will give vasovagal response, even bradycardia, then subsequently cardiac arrest. Or there is overstimulation when they are either stimulating the baroreceptors in ENT surgery when they are working close to the neck. The excessive insufflation when they are doing laparoscopic surgery, it could cause peritoneal stretching. The increase in intra-abdominal pressure that can lead to decrease in preload. Then injuries such as pneumothorax or tamponade, or there is an embolism in the pulmonary or coronary artery, or is the pathology of the patient pheochromocytoma when they are manipulating the tumor. Then from echocardiography, if we have it available, we can quickly check. It will give us the idea of the preload, what is coming back to the heart, the contractility, whether the heart is contracting well or there is disorganized contraction pattern. If we have any heart failure, you can see the myocardial ischemia, because we can see decreased wall motion abnormality in the affected area. Then what are the relevant check and history that we can take? From the ECG, we can see the rate and reading. It can also give us myocardial ischemia. For rate and reading, usually arrhythmia, usually 2 is the best to detect it, while myocardial ischemia, especially intra-op, the B5 lead is very important. Then lab result, if we have quickly take sample, check potassium, glucose, and check hydrogen ion. So our ABG come very handy here. Then from temperature, if the patient is having hypothermia, you can have cardiac arrest. Then the breath sound to check whether we are dealing with pneumothorax or we are having anaphylaxis, if the patient is having wheezing bilaterally. Then we check skin rash in case of anaphylaxis. Then patient is having cardiac disease. Maybe he may be in heart failure. So this it said, and I would not have gotten away with it too if it were not for that meddling defibrillator. So use of defibrillator is very important, especially when we have a the rhythm that we can effectively correct with defibrillator. So effective treatment of this perioperative cardiac arrest depend on two simultaneous actions that we can do. The first is immediate and effective commencement of cardiopulmonary resuscitation, and then the second cause is efficient and effective investigation in order to find and correct the underlying cause. Because if it is something that we can correct, provided that we did not correct that abnormality, the heart cannot restart. Even if it restart, the patient will go back to the cardiac arrest again. So finding the cause of the cardiac arrest is very important in order to have a better prognosis for the patient. So without correcting an underlying cause, the cardiac arrest is likely to persist or to occur. However, investigating the cause is challenging because we have a lot of potential causes of the perioperative cardiac arrest. And usually during resuscitation, when we have a crisis, the environment is just like a fog of war. So we need to implement efficient and effective and then intentional structures in order to proactively identify those underlying causes and then propagating the causes. So that's why this ASAT criteria is being developed. That will make us to follow the likely causes of the perioperative cardiac arrest sequentially, and it will now make us not to miss anything that is likely going to lead to perioperative cardiac arrest. So when investigating these underlying causes, an integrated approach that includes the head anti-mnemonic, the PCAR, which is the preload contractility, afterload rate, and rhythm construct, and then using our clues that we can get from the monitoring, then implementing our ASAT list of action should always be used. So we need to maintain an open mind when the cause of the perioperative cardiac arrest is not immediately apparent. So combination of cognitive tool can reduce the likelihood of missing or ignoring any important clue and provide a systemic approach which is highly relevant to perioperative cardiac arrest. So this is just the American Heart Association CPR cardiopulmonary resuscitation algorithm. As you know, usually when we have cardiac arrest, so the first thing is to commence CPR. So after we call for help, because it's usually a crisis, shout for help and announce having CPR. In the developed country, they say they call a code. So we commence the CPR, so we give oxygen and attach our monitor and defibrillators. But luckily, during the perioperative period, the patient is always monitored. So the monitoring are there. So that's why it is usually witness cardiac arrest. So checking the rhythm using our ECG to see if it is a shockable or non-shockable rhythm. For pulseless ventricular tachycardia and ventricular fibrillation, we promptly use our defibrillator to shock the patient. Then continue the CPR for 2 minutes. Usually our intravenous access is usually available. Then after 2 minutes, we recheck again. If it is still shockable, we shock. Then continue the CPR. Then from there, we can give epinephrine after every 3 to 5 minutes. Then we consider advanced airway, but usually in the perioperative period, most of the patients are intubated, so when you are doing regional anesthesia. And usually the expert that can intubate the patient are there. So that's why perioperative cardiac arrest has a better prognosis than other forms of cardiac arrest like the out-of-hospital cardiac arrest. What if it is not a shockable rhythm? So for non-shockable rhythm, usually the asystole and then the pulseless electrical activity. We give epinephrine as soon as possible, 1 milligram. So we continue the CPR for 2 minutes. After that, we check the reading again. If it is unshockable, continue the cycle. If it is shockable, we can shock. Then we start checking and correcting the reversible causes. So that's where we can go and look for the H and T's, or we can use our PCARR approach to find the likely thing that are causing the cardiac arrest and correct them. Once we correct the underlying cause of the cardiac arrest, usually there is return of spontaneous circulation. So you can further take the patient to ICU and continue monitoring the patient, or we continue doing the surgery there. So in conclusion, cardiac arrest is a severe perioperative complication that requires constant improvement in management. You know that CPR has saved a lot of lives. However, prompt recognition and resolution of the underlying cause is very important in reversing the effect of the cardiac arrest. So the existing cognitive tool based on the head and teeth construct highlights some possible perioperative cardiac arrest causes, but it is not comprehensive. That's why we want to use the PCARR approach and then the ASAT action plan that we can get in order to effectively manage perioperative cardiac arrest. So these are my references. So thank you very much.
Thank you, Dr. Aliyu, for your well-presented presentation. You did very well to the topic. Unfortunately, there are no questions in the chat box. As of now, the only question I could see is good evening, stars on Mars. Since there's no question in the chat box, please kindly, if you have any question, please signify by raising up of hands, please. Thank you. Dr. Beleba, do you have a question? Please go ahead and ask your question, sir. Please, if you have any question, please kindly type in the chat box or signify by raising up of your electronic hand. Thank you. For Dr. Jonathan, please, you have the floor, sir.
All right, thank you, moderator, and thank you so much to the presenter. I have a few comments and I guess a question at the end. First, my comment is, it was a very direct presentation. Lots of information covered in a short period. So I would encourage, personally speaking to myself and maybe to most of the other residents listening, after this, when the recording and the slides are shared, it will be good to take a look and also reiterate some of these things because a lot of very practical things were said. Then to maybe cone it down to our practice here, it is important to know that despite it being a rare complication, perioperative cardiac events can still happen. So proactively, you should always prepare for the possibility, which means that, like he said, witness or perioperative cardiac arrests have a lot better prognosis because some of the things that we want to do in cardiac arrest are already done. Patient already has a monitor attached, patient already has IV access. More often than not, patient maybe is already intubated, which grants you a definitive airway. So it's important to ensure that those things are done. It's not, oh, maybe you're doing regional, there's no need to put a line, or it's a short case, there's no need to have your adrenaline ready. It's important also because we understand the limitations of some of our practice. You know that sometimes the monitor is not working all the way. Like he said, the prognosis is better in developed countries because of the efficacy of their monitors. sometimes we routinely don't use ECGs or other things like that that can help. So proactively is also a clarion call that your best treatment is prevention. So when you're working up your patients, no matter how simple or small it is, ensure that you understand that it is possible that these patients can have a cardiac arrest on table. Am I prepared to deal with that eventuality? Do I have the drugs? Do I have something to intubate and put in a definitive airway? Very important to look at it like that. And then my question to the presenter will be, a few times you generally mentioned the H and the T's. So I don't know if you had a slide where you said it, but considering how common it is, could you just remind us what they are? Because that is also what I guess a lot of people are much more familiar with when dealing with the causes of cardiac arrest. Thank you so much, Dr. Ali.
Okay, thank you very much, Dr. John Appam. The H and T's are there in the slide. I don't know, maybe people did not see it well, but we can see it here. For the H, hypovolemia, hypoxia, hydrogen ion, which is acidosis, hypo or hypokalemia, and hypothermia, while the T's, the tension, pneumothorax, cardiac tamponade, or toxins, that's in the case of toxicity or maybe overdose of a medication. Then thrombosis, which can occur in either the pulmonary artery or the coronary artery. So they are the likely H and the T's that we look for when we are checking the reversible causes of the cardiac arrest. We can easily reverse them if we detect any of them, and then the patient will have return of spontaneous circulation. So thank you very much.
Thank you, Dr. Belema. Please, you have the floor, sir. Thank you, Dr. John, for your contributions and your question. So, Dr. Belema, please, you have the floor.
Good evening, everybody. Am I audible? Am I audible, please?
You are audible, sir. Please go ahead, sir.
All right, thank you very much. Thank you very much for your presentation. It was a very beautiful presentation. I just want to also build on what Dr. John Afam talked about. Looking about in terms of preparedness, one thing that we'll also need to actually focus on, especially in our various center and where we are in Nigeria in terms of we are a resource limited country. Availability of required resuscitation drugs to points of, I would have even loved you to also talk about the challenges with this perioperative cardiac arrest in terms of how many centers still do WHO checklists, and that will also help to identify things that can actually cause or even errors, even near misses, or even right equipment. How many centers or how many centers will have the AED in events, or even the resuscitation drugs in the event of the cardiac arrest. Then also identifying, that's where you talk about monitoring, identifying these symptoms. Like for instance, in the post-anesthesia care unit, most times we just hand over patients and move on. The nurses there in charge, are they also able to identify when a patient is actually depreciating, or based on the manpower issue, they may not be able? So it's a collaborative and multidisciplinary approach in terms of prevention and preparation, where identification of those people are monitoring these patients, and the promptness to actually call for help, and the skill and knowledge to even know what to do at that point. The availability of the ICU space for post-anesthesia care is also very, very important in this. Sometimes these are the limitations. The patient may have cardiac arrest or perioperative cardiac arrest and may not have availability of ICU space for that care. So this in all encompassing is important for us to, gear towards making sure that these things are not missed and also help prevent, and when it happens, give patients optimal care. Thank you.
Thank you, Dr. Belema, for your remarks. Dr. Deme Insesi, please have the floor.
All right, thank you very much, the moderator, for recognizing me. Thank you, Dr. Aliyu, the presenter, and the education team for this topic today. Please, I just need a clarification from you, Dr. Aliyu. You mentioned on one of your slides, if it were possible to bring up that slide again, you talked about cardiac arrest, perioperative cardiac arrest in patients post-op during the care in post-operative care unit, and then 24 hours in the ICU. Now, supposing a patient is sent to the ward and within 24 hours post-anesthesia developed a cardiac arrest, is that not still a perioperative cardiac arrest?
Okay, thank you for the question. When the patient is sent to the other ward and then the patient has cardiac arrest, that one is classified as in-hospital cardiac arrest. So you classify that one as in-hospital cardiac arrest. That's why later on in the slide, I gave the table showing the characteristics of the three usually different cardiac arrest: perioperative, in hospital, and then out of hospital cardiac arrest. So here, so when the patient is taken to the ward under the general nursing care, that one is called the in-hospital cardiac arrest. That's based on where I got this what will I say, this information from. So they categorize that one as in-hospital cardiac arrest. It's only when the patient goes to the ICU that they now categorize it as the perioperative cardiac arrest. So thank you.
All right, thank you very much. Because why I'm asking that question is we have had this idea that any death within 24 hours post-anesthesia, post-surgery, is anesthetic death until proven otherwise. So that's the way I was reasoning. But I'm saying, well, your source.
I wasn't hearing anything again. I don't know if she's through with her question. I don't know if she's still online with us. Maybe the network. Meanwhile, there's a question in the chat box. There's a comment by Dr. Monsuru Akimbola. Thank you for your concise lecture. At what point do we integrate during perioperative cardiac arrest prior to intubation? Can I be heard, please?
Okay, they say, at what point do we intubate during in case of perioperative cardiac arrest prior to intubation? Okay, when the patient arrested prior to intubation, maybe you are doing regional anesthesia whereby the airway is not secured. So as soon as you get the equipment for intubation available, you secure the airway of the patient, because timely intubation increases the chance of having return of spontaneous circulation, because ventilation will be more effective when you have a secured airway. So once cardiac arrest is being declared, you commence resuscitation. Maybe somebody quickly go to look for laryngoscope, endotracheal tube. As soon as they are available, you intubate the patient and then continue the resuscitation. Thank you very much.
Oh, okay, the next was Dr. from Dr. Katrina. You said we didn't hear Dr. Demes' response to. So please, do you have many? Do you have more questions from residents in the house, from senior registrars and registrars? After about 2 minutes, if there's no comment, if there are no more comments or questions from the residents, then our consultants and professors we have the floor to make their comments and remarks. So in the absence of any comments or questions from residents, please, our professors, the consultants, and other teachers, please, you have the floors. You can make your comments, contribution to the topic that was presented by Dr. Aliyu.
Hello, good evening. This is Dr. Dati.
Good evening, sir.
Okay. Thank you very much for the presentation. I joined very late. I was struggling with the network, but I had the last 10 minutes contribution and your responses to some questions, particularly the one from one of our trainers from Calabar or Uyo in Sese. I hope you understand what she's trying, the information or what she's trying to convey about perioperative. Because if the patient that is on the ward after surgery does not need to be either in ICU or recovering, but the time, the period that where you have your definition, 24 hours, then the patient is in that category. Now, the perioperative cardiac arrest, the way I understand it, when you say perioperative, on your definition, patient who goes into cardiac arrest either before or during the surgery or after, and within 24 hours, right? So, what I want us to remember is that when you look at your list for the day or the whole week as a department, you look at the bed space you have in the ICU and the types of procedure or the subspecialty. For example, there are lists, there are subspecialties when they are having their, elective procedures, you know from the beginning you're going to need an ICU bed or at least a HDU. Neurosurgery, for example, cardiothoracic, apart from those that are less invasive, but majority of, several of their major cases will require a bed in the ICU. So, but the previous day, probably you've had the bed space filled up, taken up by patients, and then you go ahead to start the list, and then you end up with cardiac arrest. Such scenario do happen, and sometimes we can't stop it. The surgeon will feel that, yes, he has to operate. We have seen many cardiac arrests, but they tend to forget. This like pediatric surgery, even obstetrics. So inherently you have this risk. They are at risk of cardiac arrest. So my suggestion is that where possible, you make your recovery room look like HDU, if you can, with the management to support you. What I mean by that is that you have a source of oxygen, maybe pipeline, where you can connect a ventilator. You can move a ventilator. The ICU is filled up, yet you have this cardiac arrest. Because the patients into the ICU, they come, quite often they come from the operating rooms. And that's why even in citing the ICU, you must consider your main operating theaters. So this you have to take note. You have to look at what you have. And a bed is mandatory for some specialties, or depending on the procedure. And then you have unplanned admissions into the ICU as a result of cardiac arrest. So really these are challenging scenarios of which you can look at your operational guidelines and theater users committee where possible to bring this to the notice of the users to appreciate these peculiar situations and risks. They are there every day. So those are some of the comments I want to make. Thank you.
Thank you, sir. We appreciate that. Thank you, sir, for such a rich contribution from Dr. Alexander T. Mohammed, the president of Nigerian Society of Anesthesia. You are well appreciated, sir. I don't know if all that.
There is a hand up there.
Yes, Dr. Solomon, please, you have the floor, sir. Dr. Solomon, please, you have the floor.
Yeah, okay. Thank you very much, moderator, and also thank you to the presenter, Dr. Aliyu Bashir. Great presentation. And I have probably a couple of comments that I want to make. I'm an emergency physician, but a good friend of the anesthetics. I like them and they like me. We work hand in hand a lot together. So when I saw this topic, and that's like our own bread and butter, so I was kind of interested. The first thing I want to say is that talking about what happens in the other climb, I mean, like what we call the civilized climb, where they are more organized, we tend to attribute everything to better equipment, monitoring, and all that. Of course, those things play roles, but we should not forget that it's also about a culture. You know, a culture where they have teams already organized with roles pre-assigned. Everybody knows what to do in case these emergencies happen. Once it happens, you just see people emerge from nowhere and everybody is in position. They know what to do, how to do this thing. So it's something that we can also try to implement here to improve the return of spontaneous circulation in order to improve our sources. Because these medications, there's nothing so special about that, what they do, like in terms of CPR and resuscitation. The medications are available. What do you need? Adrenaline, amiodarone, or lidocaine in this place, depending on circumstances. So, and that's basically the, of course, there are other drugs that may be needed based on their H's and T's after you've done that. But again, I think we can actually identify these things. So the culture that we create in our respective departments, institutions, really contribute to the success of our resuscitation. And just as a side comment to the answer Ali you gave to the question about at what point in time, if the patient was not intubated, when do you intubate? Yeah, well, intubation is not like mandatory. Even the use of airway these days, and there have been studies towards that that show how advanced airways like the iGel or the LMA or the LTA, if you have them available, these are blind insertion devices that you can just insert without interrupting the CPR, because actually intubating a patient where a CPR is going on is very difficult. One thing has to happen. Sometimes you have to interrupt your chest compression in order to intubate. And again, that worsens your chest compression fraction, which has a role, which can influence the outcome. I just wanted to say that. So as long as you are giving good breaths and then giving chest compressions, and you can use even your BVM, could suffice for a while. But as soon as you can, of course, you have to go to an advanced airway. If you don't, when you achieve ROCs, that's the right time you can calm down to intubate your patient and then provide your post cardiac arrest care. I just said that should, kind of stress these facts to us. Thank you so much.
Thank you, sir, for your introduction. Yeah, thank you. We'll get to see this. Yeah, we'll get to see the slides for those that join you to go through. Actually, usually videos of sections are always recorded and uploaded to the Nigerian site of anesthetics page. So as soon as it is uploaded, the resident representative will post it to the blog. That's the WhatsApp blog. Hello. So as soon as it is posted, as soon as this video is recorded and will be uploaded to our YouTube page. So from there, any people interested individuals can always watch over and over again. Thank you. So another person. There are no other hands up. Okay. So thank you. At this moment, if there are no further contributions or comments, I don't know for other teachers and trainers in the house, I don't know if there are other contributions. In the absence of none, I would love to hand over back to the director, to the meeting, to the president-elect, in person of Dr.
Okay, I'll take it over from here.
For the conclusion of this section, if she's online. Okay, thank you very much, sir. So,
okay. Thank you so much to our moderator, Dr. Adeboye Akintade. And I think with that, you already know, well, you're the next presenter, and the topic has already been shared on the blog. So we look forward to that. As usual, the topic, the flyer and the link will be communicated when it's nearer to the date, which is in 2 weeks. We are very grateful to the educational committee and to all our teachers and trainers who has joined in, especially Prof. Hassan Dati, the president of the NSA, who is here. So, Prof. Sir, I would hand over to you for your final comments, sir.
Thank you very much, Dr. Afam. I want to say it here that we are very proud of you all for sustaining this momentum. I think it's working. We try to give enough space and time for you to rub minds, just for your practice and especially for exams. My thinking is always towards exam because you have a mission. Most of you are trying to get the fellowship. So this is just one of the opportunities that you have, and you should maintain it. I hope you still don't mind the time that we adjusted for some reasons. We don't want to disturb the weekends. Workforce well-being in my mind. We try to do everything during the working days, although we still do meet. Our firm knows that at weekends, sometimes in late evenings, or just committee meetings. But webinars like this, we decided to put it 5 on a working day so that we don't disturb the weekends. And every topic, you should consider it very serious. Like this one, for those going for exam, you know, you cannot, there's no way you will not have resuscitation, either in OSCE, most likely in the OSCE, where you will be asked to perform. There will be a scenario. This is real. So this is good. So it's a form of revision. More so that the exam is just 2 months away or so. Some are writing the exam, I mean the CBT later this month. And then for both colleges, in the next 2 months, we have the clinicals. So this is very good. You should try and listen at least. I know we're supposed to close 4 in the operating theaters, but quite often we go beyond that time. Thank you for making out the time to be here and to listen and contribute. The best way to contribute is that once you know the topic ahead, we're supposed to read around it, because the person presenting and the person moderating, they are just, you know, trying to, they are representing us. Then at the end of it, we have to discuss. Okay, so that's why everybody should try and read so that the discussion can be interesting and then more rewarding. So I want to thank you very much for this. I don't know, you announced the topic now for the next topic, next presentation in 2 weeks' time, right?
Yes, sir. Yes, sir.
Okay. You have it on your platform.
Yes, sir. Dr. Boyega Kintade, September 2nd, he'll be presenting anesthesia management of the polytraumatized patient.
Oh, interesting. So please post it also on the main platform, because there are trainers that they like some areas, so they will try to say, oh, I must be here, you know. Like I said, you will see many consultants here. We just give you room, you know, in your own space to talk, and then to your confidence, you know. You won't know it. The time you will be asked in the exam, you just be talking because you're used to these scenarios, I mean, this forum talking. Before I forget, the last comment by the emergency physician, we really appreciate. I like what you posited by saying that, if I understand you well, we shouldn't, you know, this lack of this and that will be there with us for God knows how long. But we must imbibe the culture of being organized, and being organized, simple protocols. We know we don't get, CPR it has become second nature to us. Every day it happens, we succeed most of the time. But to improve on that, we need to imbibe that culture of being organized. You have protocols you can adapt from different parts of the world. Adapt, when we say adapt, you adapt, you input what will work for you in your environment. So that is what we need to do. Thank you once again. We look forward to, is there any other announcement, Dr. Afan?
None from this end, sir.
Okay, so we see you in 2 weeks' time. Thank you very much and have a good evening.
Thank you so much, Professor. Good evening, everyone.